And we're going to start with Dr. Jim Cerruti, and he is the CEO of TeleHealth Care Solutions. Welcome, Jim. Thanks for being here tonight. And we look forward to learning all about the VP exam.
Great, great. Thanks for having me. I think I've successfully shared my screen, but somebody feel free to stop me if I have not. All right. So I'm an invasive cardiologist is my day job, but I founded the VPExam as a comprehensive telemedicine platform, and its real focus is on problems related to transitions of care. We're trying to reduce readmissions. About 1/3 to 2/3 of rehospitalizations from skilled nursing facilities could be prevented. And many times the signs of clinical decompensation are not noticed early enough in the clinical course. So this hurts our patients, which we care most about, but also our hospitals and our nursing facilities. And CMS penalties result from poor outcomes. So telemedicine is a great opportunity, but we're missing important data. What we really focus on is the lack of physical exam data. This reduces our clinical confidence, and it can result in malpractice suits for misdiagnosis and delayed diagnosis. So we built a system focused on automated teaching and augmented reality. It walks the nurse or the patient through how to perform a physical exam. Augmented reality helps ensure that you have the proper positioning of both the camera and the distance, as well as the stethoscope. In our previous pilots, we could use this in nursing facilities and reduce readmissions by about 20%. We think there's even greater opportunities for some of our very high risk COPD and heart failure patients, our sickest of the sick. And one of the keys to working with hospital systems that I'm trying to hit on here is integration. We put a lot of focus on integrating with scheduling, billing, and EMR systems. Probably the most known would be Allscripts, Cerner, and Epic, which we can tie into. And experience has shown us that this is the integration that is required for successful telemedicine for both physicians and for patients. So this is a quick run through. This is an example of looking for changes in jugular venous distension. And by seeing that earlier and the software walking the user through, we can detect heart failure decompensation sooner. This is augmented reality just showing how to perform lower extremity edema assessments. We can do other things, range of motion, wound healing, things like that, just with video exams and the software. And then we can move on. So we've connected to Bluetooth stethoscopes. This is a Littmann 3200. We've also partnered with Echo, and they make a duo stethoscope that's pretty exciting. It can do a single lead ECG. You can hear a murmur very clearly, and the software walks the user through where to position the stethoscope step by step. And you can also do a full pulmonary exam. You can detect crackles and things like that earlier. And this is our web portal where you can quickly pull up all the data. You can also see review of systems, histories, and all the other data that's transmitted. And then you can quickly and easily shuttle the patients into the appropriate waiting rooms. So we maintain HIPAA compliance, but the physical exam is really the difference that sets us apart. The architecture of the VPExam was meant to be comprehensive. We focus on all the things that hospital systems need: easy registration, voice recognition for histories and review of systems, and the augmented reality physical exams. We can also send vital signs, medication reconciliation, document scans like EKGs and chest x-rays, as well as smartwatch data. So it's really a one-stop shop for telecardiology, which is a great niche. So in the end, the physical exam data is what really sets us apart. We can take care of very sick heart failure patients, very sick COPD patients. And we think the physical exam data really helps set things apart and our management apart. So taking a look back, we were founded in 2014. We received 2 National Science Foundation grants for innovation, around $100,000. In 2016, we started piloting at skilled nursing facilities. This is where we got to the conclusion that we could reduce readmissions by about 20%, and we could improve patient satisfaction as well, which is a great selling point. We have FDA oversight as a medical device data system, and more recently, we've been awarded a contract from University Hospitals of Cleveland to develop the Harrington Heart and Vascular Institute digital health platform. And this produced revenue of over $200,000. Evidence supports the subscription revenue could range from $500,000 and should range from $500,000 to $2 million in the upcoming year. And we're also participating in a quality improvement project with university hospitals where we're using cardiologists, nurse practitioners, and residents to improve transitions of care. This is all key to helping increase our exposure nationally. We also have two more medium-sized hospitals interested in initiation. So we plan to leverage our technology. We want to partner with various size hospital systems. We think we can sell the point that we're selling improved quality of care, improved transitions of care, and we can also optimize billing complexity. And we also want to explore the new niches of telemedicine. I mentioned telecardiology is a huge opportunity. We're going to move beyond nursing homes into home health. University hospitals has been very interested in moving to home health and the concept of hospitals at home to help reduce readmission rates. And we think this is the future of telemedicine, is to move more into the home step by step, and this helps bring the physician, the care providers into the home. So we also have some conservative financials here, and we think there's opportunities to increase this by at least 3 times what we're projecting here. Essentially, we're producing a SaaS model, and there's 2 main services. The first is an initiation service, and this is to integrate. This is that tie into the scheduling, registration, and EMR that I talked about earlier. And we think that this can easily generate $200,000 to $1 million per hospital. The nice thing is, as our system proliferates, it becomes easier for us to tie into these systems as we gain more and more experience. We also think there's a lot of room for subscription-based services, and we think this is the bulk of the market. It usually would scale based on the number of providers and the number of patient encounters per month. We can see revenue of $500,000 to $5 million annually per hospital system. By the end of 2021, we plan to partner with 5 additional health systems, which will put us in a good position for a Series A round. The seed fund that we're currently undergoing is to grow our executive team, our software engineering team, as well as our sales and marketing team, so we can grow our market awareness. We've hit on a few different exit strategies that are important. The biggest ones involve telemedicine providers, various hospital systems, and EMR developers, as well as hardware developers like stethoscope manufacturers. So we think that we can be very competitive against some of the other telemedicine platforms, especially in the niches of telecardiology and transitions of care. So the 2 main goals were to engage with investors interested in our seed round, but probably more importantly, to start the dialogue with some of the clinical leaders who we hope will see this evening and reach out to us. We're looking for motivated physician leaders to help bring this back to their hospital system. So this is my contact information at the bottom, my email, my phone number. I'd be happy to take any questions.
Great. Thank you, Dr. Cerruti, for your presentation. That was awesome. We do have a few questions, so I'll start with those from our audience. Is there any IP around the teleexam or the way that VPExam is set up?
Yeah, there is proprietary intellectual property as well as FDA oversight that we think gives us an advantage.
Great. And a second question really is around, do you have any data in a pilot, so any clinical pilots that have shown how many readmissions is what I would say, have been avoided? And what other clinical utilities have you seen with this? So I think about HEDIS metrics because I know readmission rates are one of those. So are there other metrics that you're looking at? Have you done pilots? And then a follow-up to that, what are you seeing from a patient satisfaction perspective?
Those are great questions and quite a few of them. So if I miss any of them, redirect me.
I will.
So the clinical pilots was our focus. We had multiple skilled nursing facilities, mainly in the Northeastern Ohio region. And we were able to pilot the system And we did see overall around a 20% reduction in readmissions. The biggest opportunity is for our sicker patients, our advanced heart failure, our end stage COPD patients. We think there's the biggest bang for the buck. And we have monitored the patient satisfaction closely, and patients really love when they can still see the physician who discharged them from the hospital overseeing their care. We think that really improves transitions of care. They can pick up on errors in medication transitions and other orders that may not go smoothly. So we've seen a lot there. We've also looked at efficiency. We've been able to document that we can reduce the amount of time the telemedicine visit takes. Back when I started telemedicine, I had to tell a nurse, move a stethoscope to this place, this place, this place. No, that's not right. And then move the camera here, here, and here, and it would take me 10 minutes. We could show that we could improve efficiency, and you could review the entire physical exam on the physician side in about 30 seconds, which is great. No more than a minute, and it's taking the nurses on average about 3 to 4 minutes to perform the physical exam. So it's efficient for everybody. I think that's important. Our upcoming quality improvement projects also focuses on other things, like, are we just going through the steps of doing telemedicine, or are we actually changing care? Are we altering medications? And are we making big decisions like, should the patient be readmitted or not? And those are softer outcomes, but I think they're important.
Great. So a few other questions. I think we still have a couple of minutes. So I'll come back to a follow-up on the IP in just a minute. But there was one question around what happens when a patient does need to be readmitted or emergent patient referral type of thing. Does your system help in that process? And then a second question related to that really is around any risk or liability for using your system that might be incurred, again, if a patient is getting worse and this could be missed and something bad happens in the home.
Yeah, so great questions. The way we usually set up the system to be used is we're discharging them, and we can see these patients sooner. We can ensure that they have a 1-week follow-up and then a 1-month follow-up. So we're improving the regular visit frequency, which is helpful, but more helpful is we can identify certain clinical signs and symptoms that automatically create an urgent encounter, where the discharging cardiologist, nurse practitioner, internal medicine doctor will see the patient because they've gained 4 pounds of weight, they're increasingly short of breath, they're requiring higher oxygen demands, and then the nurse is sending us the full physical exam data, and that really helps. It helps improve your confidence. I think as a physician, it's easy to panic, and you hear a nurse and they're concerned about a change in clinical condition. And some of us think, well, it's easier just to bring them back to the emergency room and let them sort it out. But really what we're showing is improving confidence, improving the data that the physician has available, listening to the heart, the lungs, and seeing JVP, lower extremity edema. It makes you more confident about what's going on and whether you can safely keep that patient in the current level of care, or you need to move them to a higher level of care. So if anything, I think it's going to significantly reduce liability. It's giving you access to more data as opposed to just usually a phone call, maybe a video visit, but we're still missing a lot of things. So I think this is a step from the cardiologists, pulmonologists, and specialists I've worked with in the right direction to help reduce liability.